Good morning, everyone. This is Dr. Amrit, and I'm a professor of pathology. Today we have a class on bleeding disorders. So before we get into the classification and the pathophysiology of bleeding disorders, I thought I should talk a little bit about the platelets and their mechanism and how they function, and what happens when there is an injury, how does the platelets adhere to each other, and what are the different types of receptors involved in the adhesion and the stoppage of the bleeding. So the first slide shows you that the platelets come from megakaryocytes, and this is the picture of a megakaryocyte, which is a multilobated nucleus with the abundant cytoplasm. So thrombopoietin is the one which helps in the production of platelets. So the normal common function of the platelets is to prevent the bleeding. So the normal lifespan is around 7 to 10 days, and the count is between 1.5 to 4 lakhs. So when do they say it is, when they say it is a risk for bleeding? So it is when there is the platelet count goes less than 20,000. That is the point. Then they call it as a high risk platelets, because there is a chances of spontaneous bleeding at any time at that point. So structure, I need not get into the detail of it. Okay, so basically the platelets releases the ADP, calcium, serotonin, and thromboxane, which helps in the platelet aggregation and adhesion. So function is hemostasis, primary and secondary. So the platelets, they adhere to the surface of the lining epithelium, or they can say the of the walls of the blood vessels. So these platelets, they adhere to the subendothelial collagen with the help of the 1-beta glycoproteins on the platelet surface. I will show you the picture of it. See, the upper one is the platelet membrane, then it binds to the von Willebrand factor, and the third one is a subendothelial microfibrils. So 1B and 2B3A are the receptors which are present on the platelet membrane, to which von Willebrand factor will get adhered, and which will adhere to the collagen surface of the blood vessels. So this is how the platelets fuse to the blood vessel wall, and they help in clotting, or you can say a plug which stops the bleeding from the blood vessels. So what happens is, when they are adhered and aggregation is happening, they release thromboxane too. The thromboxane are the one which helps in the even constriction and even helps in the stoppage of the bleeding. Now you can see calcium which is released from the platelets. It helps in the coagulation cascade, and ADP helps in the platelet aggregation. So now you can see this is left side is a normal platelets, and on the right side the clotting factors and everything, they have been fused together, and they have released their granules inside circulation. So this is how the platelets look like. So you can see on the left side this picture. You can say first step is the adhesion in the plug formation, platelet plug formation. Then we have the aggregation. Then we have the ADP released, which will invite other platelets to come and bind it. And then we have the thromboxane A2 generation thromboxane, which helps in the vasoconstriction and stopping of the bleeding. Alright, so this was a journal about the platelet disorders. Now, what are the different types of platelet disorders? You have only heard about thrombocytopenia. What is thrombocytopenia? Thrombocytopenia is nothing but the decrease in the number of platelet count. Okay, so what is the normal platelet count? 1.5 to 4. So if it is less than 1.5, they call it as a thrombocytopenia. But then you have the two other factors involved in the platelet plug. The number one is the vascular system, the collagen to which the platelet bind, and the other one is the coagulation system, which is also known as the clotting factors. So these clotting factors and the vessel wall and the platelets, these are the three important factors for the platelet plug formation. So, but we will be dealing in detail only with the platelet disorders, which is also known as a thrombocytopenia. Now, the clinical picture, if there is no platelet plug formation, what will happen? There will be petechiae, there will be ecchymosis, mucosal bleeding, and excessive bleeding after surgery, because the platelets are not able to do their proper function. So I have told you, as always, it is platelet count. If it is less than 1.5, it is known as thrombocytopenia. Now some people, they divide into mild, moderate and severe thrombocytopenia. They call it as less than 1.5, or they can say 1 to 1.5, it is mild, around 50 to 1 lakh is moderate, and 20 to 50 is severe. And if it is less than 20,000, it is acute emergency. So you have to infuse the platelets into that patient, otherwise a sudden hemorrhage or bleeding can happen even in the brain, which can lead to hematoma formation and even leads to the brain death. Okay, so decrease in the number of platelets is called as thrombocytopenia. Now this decrease happens because of many reasons. First of all, it can be a failure in the platelet production. Megakaryocytes are decreased in the bone marrow because of any reason. There are no megakaryocytes, so no platelets are formed. Example is the drugs. They suppress the bone marrow, or there is a malignancy involved in the bone marrow, or there is some HIV infection and associated some viral infections, and sometimes the nutritional factors also lead to the decreased production of the platelets. Now the second reason can be the marrow is producing enough, but when they are released into the circulation, they are destroyed by the antibodies. So what are these antibodies? These are the antibodies, autoantibodies, which go and act against the self-antigens. Platelets are self-antigens. So normally the antibodies are not supposed to act against them, but if they go and act and destroy them, we call it as a idiopathic thrombocytopenic purpura. Okay, and it also presents in other forms like TTP and DIC, which I'll be talking in detail later. Now the third reason is production is okay, removal is not happening, but because of some massive exchange transfusion, the platelets are getting getting removed, or they are getting utilized. And also example is a cardiopulmonary bypass surgery. And the fourth reason could be the patient is having some splenic enlargement because of thalassemia, because of Gaucher's disease, malaria, Kala Azar. So all these because of these conditions, the platelets are getting stuck inside the spleen, which causes a splenomegaly. So the platelets are there, they are normally present, there's no antibodies, but they're stuck inside the spleen. So that is why the circulation will show features of thrombocytopenia. So sometimes I feel like I'm a radio jockey here. I'm not able to listen to my students and find out what exactly have they understood or not, but this is the best way I can reach you. So if you still have a reason or a problem in understanding, you can get back to me. I will be able to clarify all your doubts. So let's see what are the infectious causes of thrombocytopenia. This is the first one is a CMV, or viral infections, rubella, toxoplasmosis, syphilis and herpes, and all these infections may also causes the suppression of the bone marrow, which might result in decrease in the platelet production. Now there's another one terminology known as pseudo thrombocytopenia. Pseudo means the platelet count, everything is normal, but there is a faulty collection of blood. Because of the faulty collection of blood, the platelets are either aggregated, okay, or the platelets are fused together, and the machine is not able to calculate the exact amount of the platelet count. Okay, so in those situations, what do we say? We ask for a citrate sample. We tell the clinician there is a faulty collection, the platelets are getting aggregated in the EDTA tubes, so we want the sample in a citrate or a heparin, which will help them to prevent them from coagulating, and we can have a true we can have a true count of the platelets. Now let's see what are the causes of thrombocytopenia. Causes are acquired and congenital. The acquired causes are actually more common. The first one is Amino Thrombocytopenia, we have discussed. TTPs, thrombotic, when there's an increase in thrombosis. Now in coronavirus, as we are seeing in this world, there is a lot of thrombosis. DIC is happening and the platelets are getting consumed in thrombosis. So that is why the patient presents with DIC, bleeding. So in DIC, what happens? There is a thrombosis and there is a thrombocytopenia. Okay, so drugs, infections, splenomegaly, bone marrow suppression, and plastic anemia. While in congenital, we have TAR syndrome or the Viscott-Ehlers syndrome, a little bit of which we will touch a bit later. So let's talk about the Amino Thrombocytopenia. Now, Amino Thrombocytopenia, as I've told, it is an autoimmune disorder in which the platelets are acting against the platelets. So the first one, it can be acute. It's more common in the children. It just happens and it goes away with the viral infections, different viral infections. Even in dengue, everything, when there's a single episode of dengue infection, the platelet count goes down. But that is not a cause of immunothrombocytopenia. That is just a cause of thrombocytopenia. That is an infectious cause of thrombocytopenia. So what I'm trying to explain here is acute, one episode and then it goes away. It never happens again. So any viral infection can cause you acute thrombocytopenia. But if it is adult patients and if there's a repeated thrombocytopenia which keeps coming after every 2 months, 3 months, and it continues for more than 6 months, we call it as a chronic thrombocytopenia. Okay, so what is the pathogenesis? The platelets, they get sensitized with the autoantibodies, and these platelets, which are enveloped by the autoantibodies, they are removed by the macrophages of the spleen and they are destroyed in the spleen. So there is not enough platelet counts for performing their function. So as I've said, if it is acute, it is self-limited, and because it is acute condition, short time, the bone marrow will respond and you will see increased megakaryocytes in the bone marrow. So, and only 5 to 10% of them will get into chronic ITP because most of the time, these complexes are removed by the spleen and the body is free of these autoantibodies. And since this is because of the viral infections. Now, the chronic ones, they are some antibodies which are going to last for a longer time, for a quite insidious onset, and sometimes many of the time it's 50 to 60 years ladies, they will come with the thrombocytopenia every 6 months. So you just have to treat them on steroids and infuse them platelets so that the platelet count is kept in check. So manifestations. So before I get into the manifestations, I would like you to know that the one difference between the platelet and the coagulation system, there are factors, coagulation factors 1 to 12, which helps in which is known as clotting factors. So the symptomology in the clotting factor diseases are more severe than this thrombocytopenia. Thrombocytopenias will show mild BTK, some mucosal hemorrhage and splenomegaly. But in the coagulation disorders, the bleeding will be huge. It will be in the bigger organs, huge bleeding, and hemarthrosis will happen, and hemarthrosis is nothing but a bleeding inside the joints. So in this picture, you can see on the left side we have BTK, which are small, less than 3 millimeter in diameter, and then the ecchymosis, they are big bleeding in the subcutaneous tissue. So the left side, it is because of the bleeding disorders, and the right side will be most probably because of the coagulation disorders. But if there is a severe thrombocytopenia less than 50,000, these types of bleeding might appear, but it's not a usual finding. All right, so in this picture you have seen these are some of the giant platelets which are seen. Giant platelets are nothing but before they become actual platelets, as an intermediate one step between the megakaryocyte production of the platelets. So these are supposed to be in the bone marrow. Since the platelets are less, so there will be more production and these will be thrown into circulation. So these are just an indication that the bone marrow is producing enough amount of platelets. There is some problem in the circulation that they are getting destroyed. Okay, so now you understood about the thrombocytopenia. The causes can be congenital and acquired. Acquired also we have spoken about many causes, and congenital there are mostly 2 to 3 causes. Now this is the vascular defects. Vascular, I've told you before, other than the coagulation and the bleeding, there can be a defect in the blood vessel wall. as you have seen most commonly in Marfan syndrome or Ehlers-Danlos syndrome. So what happens in these vascular defects? So these are the, in which there is an inadequate collagen formation. Because of that, the platelets are not able to adhere. Platelets are not able to perform their normal function. So with the result, there will be a bleeding. So you can see in the lower picture, this is erythema multiforme. This is, again, you can see multiple petechiae and ecchymosis you can see in these conditions. And on the right side, you can see vitamin C deficiency, which has caused this bleeding of the gums and the swelling of the gums. So the most important in this vascular disorders is platelet count is normal, prothrombin time is normal, everything is normal. Even the bleeding time can be just normal, or sometimes with tourniquet test it can be a little abnormal, but there is no massive bleeding here. Okay, so you might see some vascular fragility, bruises, gum bleeding, hematuria, nosebleeds, GI bleeds, which is also common in the bleeding disorder. So that's why whenever you get a patient of bleeding symptoms, you have to know that there are 3 different reasons. It can be a vascular, it can be a platelet, it can be a coagulation system. Now for that, what you have to do is, first you have to run a CBC. Alright, in the CBC, if the platelet count is less, then you're dealing with the thrombocytopenias, platelet disorders. If the platelet count is normal, then you are dealing with the vascular disorder or with a coagulation disorder. Okay, now if you do a PT APTT in the lab, if PT and APTT are abnormal, then you are talking with then you are dealing with the coagulation disorder. But if PT APTT are normal, it means you are dealing with the skin disorders. Okay, so this is how you assess the condition which is causing the bleeding. So because today's class was bleeding disorders, so you have to understand this part. Now we spoke about the DIC and TTP. So I just wanted a small touch of on this topic. So this one bacteria known as the Shigella or the E. coli, they usually causes the diarrhea in the patients, but sometimes these are the drugs which causes the thrombocytopenia. These bacteria causes the thrombocytopenia and even hemolytic anemias. Okay, because these bacteria, they go and destroy them as well. So these the exact causes are not known, but many drugs also has a similar effect, like quinine. Immunosuppressants and cancer drugs also have the similar effect, and sometimes a predisposing factor which is present on the von Willebrand factor will also cause a similar effect. So in the lab diagnosis, what you will see is thrombocytopenia and hemolytic anemia. So in the hemolytic anemia, what you will see, helmet cells, you will see spherocytes, you will see polychromatophilic cells and nucleated RBCs. And so just because the patient is losing blood, the RBCs are getting destroyed, the HP will be less, but the polychromasia will be there and reticulocyte count will be high. So in these cases, antibody test, Coombs test, which is performed basically to find out the type of hemolytic anemias, that will be negative because there is no autoantibody. It is happening because of the bacteria. So if you see thrombocytopenia and anemia, when also you see fever in the patient, and also you see the transient neurological deficits and the kidney failure associated, then you call it as a thrombotic thrombocytopenic purpura. It is the same thing affected by E. coli and Shigella, but if you start seeing the neurological symptoms and the kidney failure, you call it as a TTP. Okay, so this was all about thrombocytopenia. Now it is not only the platelets, in fact it can not only be a decrease in the platelet count or increase in the platelet count, there can be a problem with the platelet function. Can you imagine if there is a problem with the platelet addition, or if the platelets do not perform and they do not release ADPs and collagens and whatever is required to release into the circulation, the secretions which it releases. If it does not release, what will happen? The platelet function will not be happening normally, or if there is a absence of the receptors which are present on the platelet membrane, glycoprotein 1b, I've showed you, 2b, 3a. If these receptors are absent, obviously they won't be able to bind to the von Willebrand factor and they won't be able to form the platelet plug. Right? So there can be a defect in the platelet function also. So these are the next few slides are just to tell you that it's not in the bleeding disorders, it can be a platelet number which is affected, but very rarely, these are not very common conditions, but very rarely there can be a problem with the platelet function as well. So this can, most commonly it happens after taking this drug aspirin. For what do we, in which condition do we prescribe aspirin to the patient? In all the thrombotic disorders, in myocardial infarction sometimes, because of the patient have an increased tendency for the thrombosis, so we prescribe them aspirin. Why? And then when we give aspirin, platelets are not able to adhere and they are not able to form thrombosis, but in the meantime they are not able to stop the bleeding. If the patient tends to hurt himself or herself, the patient is the bleeding is not getting stopped. Okay, so it's most commonly happens because of the aspirin, and aspirin is the one which affects the platelet function and aggregation. So if you do a platelet aggregation test, and you will see the patient will not respond to the collagen in the test. Okay, so these are the other qualitative tests. Because of the receptors and everything, this slide shows some of the pictures and the diseases which are associated, which is not very important for you, but you should know that these things also exist. Now imagine if there is a defect in the von Willebrand factor. So in the platelet aggregation test, it will show a flat curve to ristocetin. Okay, so as a lab technician, you should know that for any bleeding disorders, what types of tests that you have to do. CBC, as we have understood, for the platelet function. Then BTCT is one more thing. Then the third thing is PT-APTT, which we do. That is mostly used for coagulation function. And for the platelets, we have to have the platelet aggregation test. So this is the platelet aggregation test. So this is a little bit detail of this Glanzmann thrombasthenia. Not very important for you. If you don't have time, you can skip over it. But I do believe in giving some extra knowledge and extra information to the students, so that in case they have a doubt or if they want to refer something, they can do it. So storage pool disorders, it is not important for you. You can leave that. Gray platelet syndrome also you can skip. The next is the thrombocytosis, when the platelet count goes more than 4 lakhs. Okay, it is most commonly happens in iron deficiency or Hodgkin's disease, but if the count is more than 8 lakh, you have to start thinking about the myeloproliferative disorders. Okay, but before you label the patient as thrombocytopenia, please check with the history, with the sample, and whether the patient is pregnant or not, because if the patient is showing history of arthralgia or anything, you have to rule the viral infections first, and and then HIV and malignancies. This is very, very important to first label the patient as thrombocytopenia. Okay, so the workup, as I've told you, peripheral smear. You can also look for cystocytes and spherocytes and NRBCs in case of HUS or even TTP. Then bone marrow biopsy can be done on ITPs. ITPs is nothing but idiopathic thrombocytopenic purpura. So in these, if there is a decrease, obviously there is a fibrosis or infiltration. If it is increased, obviously it is a peripheral loss. So how do you do a bleeding time in the lab? It is not very much commonly used nowadays, but there are two ways in which you can do it. One is the simple test without a tourniquet, and the other one is with the tourniquet. So what happens is, if you just give a prick to the earlobe about 3 to 4 millimeters deep, the time to which the bleeding stops is about 1 to 3 minutes. This is known as a bleeding time. But you can also put a tourniquet on the arm and keep it to 40 millimeter of mercury, and then of this pressure, and then give an incision 3 millimeter deep, and you will see the bleeding time will be 3 to 9 minutes. Okay, so this is known as a template bleeding time. Then we have the platelet aggregation, which I've showed you the graphs above. Every disease will show the aggregation is stopped to one particular component, which can be a collagen or ADP or ristocetin. So this is the machine which we use in the laboratories for the measuring the aggregation. So in this also you can find out the primary wave and the secondary wave, which is not required for you because it's little too much in detail, which and only if you're working in some specialized hematology labs, then you have to understand this part. But for your exam point of view, these things are not very important. But if in case you need to refer them after your exams or if you start working in a lab, so this is a quite a good backup for referring and of how to use it and how to do the things. So how do you treat the patients? You just give them gamma globulin. You try to replace the platelets first, but if that is not happening, you give them gamma globulin. That will just not improve, but it will just help them to keep the antibodies away. So steroids can be given, and then splenectomy is one of the other things which can be done. In 50 to 75% of the patients, it really improves, and that's mostly indicated in chronic ITP patients, not with the mild symptoms or the acute symptoms. So that's a last treatment. So as you can see that bleeding disorders, it is important. First of all, the classification is important. Then you have to know the etiology, and then you have to know the lab diagnosis. So I've given you an overview, and I hope you have understood it. And get back to me for any queries or any questions. And I always like to know the problems which the students are facing so that I can help them out. Do try to read Ramnik Sooth for the test, and also make notes and get ready for the exams. Thank you so much for your attention, and I think we are done here. All right, then goodbye.